Thank you, ma'am.
Then Dr. Chaitanya and lastly will be me. Right? Yeah. So I'll announce the opening. Good afternoon and welcome everyone. Thank you for joining us for today's webinar. My name is Dr. Amit Borse. I am a
Good afternoon, ma'am. Dr. Umesh Jindal, ma'am. Good afternoon.
Good afternoon. Hi.
Good afternoon. Good
How are
afternoon.
you, ma'am?
Hi, everybody.
Hi.
Hi, everybody.
Hello.
Yeah, good afternoon, ma'am.
Hello, Sunita. कैसे हो?
Yeah, thank you, ma'am, so much. Thank you for joining us.
नहीं, you have given me an opportunity. Why would I miss
अरे
it?
मैम मैडम भी आ गई हैं. मैम अनम्यूट करिए. डॉक्टर चंद्रावती मैडम इज देयर. या
Hello,
मैम
madam.
Hello,
नमस्ते.
madam. Hello, कैसे हैं?
जतिन आने वाले थे तो कहाँ चले जाते?
Hello, madam.
हेलो,
How are you?
वेरी फाइन, लवली.
Yeah, great.
अब गाना वाना नहीं चलेगा?
मैम क्या क्या करवाएंगी? फोटोग्राफी ही इज लाइक वंडरफुल.
क्या करें? हाँ, वन एंड ऑल है.
प्रोफेशनल्स को भी छोड़ के. हाँ,
वन एंड
तो आपको
ऑल.
पता ही है, वन एंड ऑल.
हम तो जतिन का गाना ही सुनने जाते हैं, तो पढ़ाई कौन सुनती
सच
है?
बात है, बिल्कुल सही बात है.
तो वी आर वेटिंग ओनली फॉर अमिता मैम एंड
अमिता ने ज्वाइन नहीं किया अभी.
अभी तक तो मुझे नहीं रिफ्लेक्ट हो रही है मैम.
अच्छा दिनेश, जरा सा बात करो डॉक्टर अमिता पांडे से. आई थिंक कर ही रही होगी वैसे.
हाँ, वी हैव 2 minutes टू गो.
मैं करता हूँ.
ठीक है,
और कोई नहीं.
यू कैन टेक 4-5 minutes, कोई बात
Yes,
नहीं.
yes.
ठीक है.
Rajiv sir, I'm making you a co-host. Rajiv sir, you can unmute yourself.
Yeah.
Thank you, sir.
राजीव सर है ट्रेवलिंग, गाड़ी में बैठे हैं.
मैडम ट्रैवलिंग कर रहा हूँ. कैसे हैं?
हाँ, गाड़ी में बैठे हैं, गाड़ी में.
नासिक से बॉम्बे आ रहा हूँ.
ओह,
मैंने कहा हेलो कर लूं मैडम को.
सर आपको मोबाइल में शायद जतिन शाह सर दिखाई दे रहे हैं. मैम भी है, उमेश जिंदाल मैम भी है, चंद्रावती मैम भी है.
जतिन साहब नहीं दिखाई दे रहे.
आप स्क्रॉल करो, स्क्रीन स्क्रॉल करो.
अमिता मैडम ज्वाइन कर चुके हैं.
अच्छा बस ठीक है.
सब दिखाई दिए. जतिन सर कैसे हैं? गुड इवनिंग सर.
Rajiv, hi. How are you?
आई एम फाइन सर.
हाँ, नासिक टू मुंबई जा रहे हो?
हाँ,
नासिक से मुंबई आ रहा हूँ.
सर थ्रू आउट जर्नी मास्क
वर्किंग करके आ रहा हूँ.
Oh my God.
क्या बोल रहे हैं?
बोला you have to wear a mask for the full 3 hours.
सर पूरा मास्क कंटिन्यू पहने रहता हूँ. उतारता ही नहीं हूँ कहीं पे भी.
अच्छी बात है.
क्या है कि अभी जून से ट्रेवल कर रहा हूँ, तो ये थोड़ा प्रिकॉशन लेके चलना पड़ेगा. आदत में आ गया.
दिस इज द ओनली प्रिकॉशन, यही है आपके पास और कुछ नहीं है. हैंड वॉश एंड मास्क.
Yes, madam. Mask is like a vaccine for us now.
आप लोग वैक्सीन कब दे रहे हो?
वैक्सीन हमारी मार्च में आ जाएगी मैडम.
आ जाएगी.
ऐसा अभी चल तो रहा है प्रोसेस में, पूरा बहुत फास्टली.
आपका किनके साथ है आपका?
हमारा खुद का ही है. एमक्योर खुद वैक्सीन कर रहा है.
खुद का ही बन रहा है.
गवर्नमेंट ने मैडम खुद को हमको भी परमिशन दिया है एमक्योर को.
एमक्योर गवर्नमेंट इज फंड.
अच्छा, तो किस स्टेज पे पहुंच गया?
मैडम दिस इज नाउ
फेज 1 का ट्रायल का परमिशन मिला ना सर अभी हमें?
अभी तो फेज 1 का मिला, फिर तो टाइम लगेगा।
फेज 1 तो हो गया,
फेज 1 हो गया,
फेज 1 का तो फेज 1 हो गया, फेज 2 का अभी मिला है।
चलो चलो ठीक है, जैसे
mRNA वैक्सीन है मैम, द लेटेस्ट टेक्नोलॉजी जो है ना।
पेंडिंग रहा।
अभी अमित वो जो डॉक्टर रंजीत जोशी ने वैक्सीन लगाया वो कौन सा वैक्सीन है?
नहीं वो सर वो जो चाइना में लगी हुई थी ना, द वन विच वाज यूज्ड इन चाइना, पर उसके
हाँ
200 डोसेज ही आए थे, वायल्स।
200 ही डोसेज आए, जिसमें नरेंद्र मोदी को लगा, एक शरद पवार को लगा, और एक बाकी मतलब टॉप मोस्ट लोगों ने ले लिया वो।
जिनके कनेक्ट थे वो ले लिए
मैं
जिनके
मैं
कनेक्ट
यहाँ
थे।
ये
डॉक्टर रंजीत
व्हाट्सएप
जोशी को
न्यूज है कि एक्चुअल न्यूज है?
नहीं नहीं, एक्चुअल मैं अभी डॉक्टर रंजीत जोशी को मिल के आया, यहाँ पर एक डॉक्टर है
अभी हम
नासिक,
नासिक में ही है मैम, तो
वो
उसमें
उन्होंने
मिला।
हाथ खोल के दिखाया, बोला देखो मैंने तो वैक्सीन लगा लिया है, अभी मैं इसका ट्रायल भी कर लिया है, मैं कोविड पेशेंट के साथ रहा 4 दिन, मेरे को कोविड नहीं हुआ, बाकी सबको हुआ। मैंने कहा ये कौन सा वैक्सीन है सर? ये बोला चाइना ने डेवलप किया था बीच, सीरम के हाथ लगा कुछ 200 डोज, तो उन्होंने टॉप टॉप लोगों को दे दिया।
नहीं तो चाइना से ली हुई चीज लगानी है हम लोग को।
नहीं लगानी है
नहीं लगानी मैडम, नहीं
सबसे बड़ा
लगा।
चीज तो है कि चाइना को जब नहीं लगाना तो कैसे लगा लिया।
ये सीरम के हाथ में कुछ
मैडम
लगा था मैडम।
ये चाइना को गले लगाना बड़ा गलत है। इससे बेटर तो कोविड को लगाना गले ठीक है।
ये बात आपने सही कही मैडम।
मैडम
अरे
सबसे बड़ी
बिल्कुल
बात है
पक्की
मोदी जी
बात
को
है
भी
यही।
लगाया गया,
हैं?
सबसे बड़ी बात है मोदी जी को भी लगाया गया।
नहीं किस बिल्कुल ही नहीं लगाना चाहिए। मोदी
दिया
जी तो
होगा।
मना किया हम लोग को
मस्ट बी रूमर।
मैडम
चाइना से करना।
मोदी जी ने लगवा लिया मैडम, देखो।
कल
वो
जो
पता करना पड़ेगा, वो
स्पुतनिक
मानेंगे
का
नहीं।
सिग्नल आया रशिया से, उसका क्या हुआ?
वो
तो
रशिया के थ्रू
रशिया की
रशिया
वैक्सीन
से
भी तो
घूम
लगवानी
के
है उनको।
नहीं, रशिया से घूम के आया होगा चाइना का चीज, डायरेक्ट आया ही नहीं होगा, ये ट्रम्प के थ्रू आया होगा।
सही बात।
ट्रम्प के
मैम इट
थ्रू
इज
आया होगा,
ऑलमोस्ट
ये ज्यादा
5
सही है।
o'clock.
या
नाउ स्टार्ट इट या
अमित, वी कैन स्टार्ट। यस
Yes. So I'll just open it and I'll hand over. Okay. So good afternoon and welcome everyone for joining this webinar. My name is Dr. Amit Borse and I'm a group product manager with IVA, a division of MCure Pharmaceuticals Limited. MCure is a pioneer in the field of gynecology and IVF, and we are committed for academics in these difficult times. We are also very happy to announce that this will be our 142nd webinar in this 6 months. And there have been other digital initiatives which were for patients and other type of small academic activities which has been initiated for understanding the therapy updates. Today we are very thankful to IFS UP chapter to give us an opportunity to host this event. May I now give it the stage to Dr. Sunita Chandra ma'am, Secretary IFS UP chapter, to take it forward. Ma'am, all over to you.
Yeah, thank you, Dr. Amit. And on behalf of UP chapter Indian Fertility Society, I welcome you all. Greetings from Lucknow. In this corona pandemic, I think this is the only way that we are meeting each and everyone, and we are seeing each other. So I think this is a good way to interact with each other and to know each other's well-being, that everybody is okay. So today we have, I welcome Dr. Chandravati, our mentor. Without her, we are not complete. We don't do any program, and any program cannot be complete without her. Then we have Dr. Umesh Jindal with us. She is Director, Jindal IVF Center, Chandigarh, and she is Organizing Secretary 2020 Fertivision. She will be speaking something about Fertivision, and I also request everyone to register for Fertivision 2020. It is going to be a wonderful conference. And on top of that, today we are welcoming our speaker, guest speaker, Dr. Jatin Shah. Everybody knows him and everybody, waits to hear him. I am hearing him for maybe for last 20 years, and every time I hear, every time I listen him, it's a pleasure. It's a pride moment for all of us that he is with us today. So without wasting much time, I hand over the mic to Dr. Amita Pandey.
Good evening to all of you. I joined my secretary, Dr. Sunita Chandra, in welcoming you to this very interesting webinar with a pioneer and stalwart of assisted reproductive technology in India, Dr. Jatin Shah. So, without wasting much time and without much preamble, I will first invite our dynamic patron, Dr. Chandravati Madam, to motivate us and bless us with her kind words. Dr. Chandravati, I am sure, needs no introduction to anybody all over India. She has been the ex-head of Department of Obs and Gynae at KG Medical University. She's a professor emeritus. She's the director of Krishna Medical Center, Lucknow, and has boards and boards of such great work to her credit. So, without wasting much time,
Thank you, Amita.
please bless us.
बायोडाटा छोड़ दो. Thank you very much. मेरा स्लाइड हटाओ तुरंत. थैंक यू अमिता, आप आए, आपका इंतजार कर रहे थे हम लोग बड़ी देर से यहाँ पर. And it's nice to see everyone on the screen today, and I'm very happy to be here with this webinar where we have such a wonderful person as a academic specialist today, Dr. Jatin Shah. I'm thankful to MQR people for organizing this webinar and Sunita for making this possible for all of us to listen to Jatin, who is one in all, a person whose talents are difficult to describe. And I'm sure each one of us and many people who will be logging will thoroughly enjoy his talk, because he just talks practical, and that is what we want to listen to. And I would not waste time. Ask Amita to start the academic session because we do not want to waste time here and there. And Jatin, welcome for this wonderful talk. And before that, I welcome Dr. Jindal, and I would wish that she would talk about her conference which she is going to organize, and we will be anxiously waiting for that conference. And later then after that, Jatin can start his talk. Thank you very much.
Thank you so much, madam. So without wasting any more time, I will now invite our guest of honor for today's function, Dr. Umesh Jindal, the charismatic director of Jindal ITF and the organizing chairperson of 40 Vision 2020, to give us her short, sweet message and encourage us and inspire our budding ITF specialists. Dr. Umesh Jindal, please.
Thank you. Thank you. Thank you, everyone. Thank you, Sunita. And I would I would say that I'm taking away Dr. Jatin's time. So I will try to be very brief and just to the point. I would like to just highlight few of the things which our team has worked very hard to put together. This is our first experience to hold the virtual conference. And so there would be some deficiencies, there would be some lacunae, but we have really worked hard, and I would like to highlight some of the features of this conference which we are going to there. So can I share my screen?
Yes, ma'am. Please go ahead.
Okay. So you can see my screen?
Yes, ma'am. Full screen. You can go ahead.
Okay, fine. So this is the first, this is the 16th annual conference, the Fertivision we all have been going to every year. And this is first virtual and a global conference because we are having faculty from all over the world. So this is the first virtual major conference of the year. And we are going to have workshops on 29th November, which is not very far off, just 10 days away, and conference on 4th to 6th December. The theme is excellence through research and innovation. And we have the, stalwarts of research in the field who are coming to talk to us and share their experience. The conference has been awarded 15 ICOG points, credit points for conference, and 2 points per workshop. So every participant will be able to get 19 ICOG points. And this conference is being jointly organized by Chandigarh, Haryana, Punjab, and Himachal Pradesh chapters of Indian Fertility Society. We have 10 workshops on 29th of November, and all these workshops program has been finalized. The people have worked very hard, their conveners, their mentors, and the faculty, they are actually working very hard behind the scene. And all the program is available on the website. If you launch, if you go visit the website, Fertivision 2020, you will be able to see the program, detailed program of each and every workshop. There are 5 workshops in the morning, 9 a.m. to 1 p.m. and 5 workshops in the afternoon, 2 p.m. to 6 p.m. And after the workshop, we have quiz also from 6 to 6:30. I will come to that. So just to highlight that this conference has been recognized by many international societies like International Federation of Fertility Societies, British Fertility Society, Middle East Fertility Society, and we have 10 many, almost 60, more than 60 international faculty is going to be here. For young minds, we have oral and poster presentations. We have already received nearly 100 abstracts. Then we have quiz. And for industry, we have trade exhibition, product theaters, where they can launch new products, or they can, have some speakers, or if you want to highlight any of their product, they can do that. And numerous branding options and much more is there. So this is glimpses of some of the our stalwarts who are going to be there, and presidents of many societies who have agreed to come. And a few of these our star speakers whose flyers are there. They are there, like Jane Stewart, David Gardner. I think all of you have heard his name. His book has been read by everybody. Linda Goodis, Jason Karase, and Dennis Sakas. So, but these are just few names, and every name on the list is a specialist. And this is we have 3 halls. It's going to be a virtual platform, and you will be able to enter the hall like you do in any of the conference auditorium or convention center. And you can roam around in any of the hall. You can go to the exhibition. You can do everything. And we are, just to detail the program of a day, we have 3 halls. So in one hall, we'll start at 1 o'clock or maybe 12 o'clock. I think the poster session will be before free communication. We are not able to get the parallel session. So we'll start the posters at 12 o'clock, and then free communications oral at 1 o'clock, 1 hour session. So we'll have 5 papers per hall, a total of 9 sessions for 45 oral presentations would be there, and nearly 100 poster presentations can be there. And 2 to 3 on Monday, there would be, on 4th, there would be inauguration, and other meetings would be there on 5th and 6th. And then we have keynote oration by David Gardner on Monday, and every day we have a very highly acclaimed speaker. And then we have a session of plenary session of 20 minutes, 3 talks of 20 minutes each, followed by half an hour discussion. So we have a very good discussion time here. And then we have President's oration, Sudha Prasad, on day 1. And then this is followed by a break and visit to exhibition and product theaters. And then we have panel discussion. On the first hall on day 1 is refractory endometrium, and this is also a very esteemed panelists who are there. This is an old slide. We have already finalized the program. You can visit the website and see the final program. And this session has been will be done by the Middle East Fertility Society. So all the international speakers are there, and then followed by another keynote oration by Hugh Taylor, President USA. And then lastly, to top it up is the quiz. So it's a long program, but it's going to be a very attractive program. So abstracts today was the last date. It was 15, but because of Diwali, we extended the date to 20th, and we are going to close because we are already having more than 100 papers, and I don't think we can have more than that. So we'll be refusing because of the time. If somebody wants to submit, you can submit it today. So this is the last day, you can still do it. The quiz is being done by Dr. Aswath, and it's a Kahoot based or an app, mobile app based quiz program. Everybody can participate. More than 2,000 people can participate, and there will be 3 quiz sessions on 29th, 4th, and 5th, the last day after the session, on for half an hour. And prizes are very attractive. Prizes have been decided: 10,000, 7,000, 5,000. First, second, and third positions, and also 3 prizes of ₹1,000 every day. So we are going to have, on every different day, winners would be announced. Registration is mandatory for all faculty member, and you have to fill the form. Registration is complimentary for IFS members, but everybody has to submit the form. This is the issue which I would like to highlight to all IFS members, that they have to submit the forms to get the links. Even non-members can become members now, and the link is there from Fertivision website also, and they can enjoy free complimentary conference participation if they become member now. So everything can be done very easily, and we even have added the link to know your membership number. That also has been added. So even if you have forgotten your number, you can see, you can get a direct link from the website for that. So and this flyer, you have a mobile flyer. You have a mobile flyer where you can open it and you can click there, and you can get the reach the website directly from this flyer. Then free communications are there. I've already talked. And with that, I would like to thank everyone for listening, and also Sunita, and I would like Sunita to say a few words and reinforce, and I would really invite everybody to join this conference. This is a unique conference where so much of galaxy of speakers is there, which usually you will not be able to find anywhere. So Sunita, would you like to add? And with that, I would like to thank the organizers for giving me this time.
Yesterday only we had a meeting with Ovam Pickup and ET Workshop, and the program is really wonderful. It's not that it is Fertivision isliye अच्छा है, but otherwise it's really a very good program for everyone. And I am motivating all the members of our society to become IFS members, because in 7,000 you become member also, and you are getting the entry to conference also. So registration is must. This is okay, because everybody is going to get a link for that. Registration is must. This is for the audience. Registration is must, whether it is IFS member or non-IFS member. For IFS members, it is free, complimentary registration. For non-IFS, you have to pay a minimum amount of 3,500. So that's all. And this conference is going to be a very good conference. And I mean, you are not going to forget this conference, because we are having more than 50-60 international faculties. जिनकी हम किताबें पढ़ते हैं या जिनकी हम जर्नल्स पढ़ते हैं, उनको we are really going to hear them
and see them also.
See them also, right. So Amita unlock karo.
Sorry. So with this, we would now request our vibrant secretary, IFS UP chapter, Dr. Sunita Chandra, to introduce our star speaker for today, Dr. Jatin Shah. Though I also feel that he does not need any specific introduction. Yes, for managing to get hold of Dr. Jatin Shah to speak for us, I think the credit goes to Dr. Sunita, and she should get the privilege of introducing him.
Yeah, so it's really a privilege for me to introduce none other than Dr. Jatin Shah. As I said, I'm hearing him maybe for more than 20 years, and I really love his talks. And I think everybody loves his talks because he's very practical, as Dr. Chandravati said. And the second thing is that, I mean, he's so versatile. And जैसे अभी मैडम ने बोला कि we are there for his songs, and now I know that he's a very good photographer also. I've seen his photography, like he beats professional photographers. So without wasting much time, I'll just invite our guest speaker today, Dr. Jatin Shah, to talk about from follicle to live birth, secrets of success. So sir, now the dais is yours, and we are there to listen to enjoy your talk. Thank you, sir.
Thank you, Sunita. Thank you so much. I'll just share my screen.
अमित सबको म्यूट कर दो प्लीज.
Yes, ma'am. It is already done.
बस, थैंक यू.
Is it visible properly?
Absolutely, sir.
Thank you very much, Dr. Sunita Chandra, respected Professor Chandravati. I know her for more than 2 decades now. Always gorgeous, charming, and as witty as ever. She's not changed one bit over the past 20-25 years. Respected Dr. Sunita Chandra, thank you so much for inviting me here today. Dr. Umesh Jindal, your conference program looks absolutely mind-blowing, and I'm sure it's going to be a great success. In fact, I think I'll participate and register too. Dr. Amita Pandey, and of course, all the lovely delegates who have turned out here in huge numbers. I think we've crossed 100 already. Of course, the UP chapter of the IFS and the IVA division of MCure for hosting this event. They've done a truly fantastic job. In fact, I've had the pleasure of participating in quite a few of their webinars. And today's lecture is actually a kind of a compilation of all the lectures that I have prepared, because I had so much of time to research and really fine tune things. And it's a compilation of all that I learned over the past 6 or 7 months, besides, of course, what we normally practice in day-to-day IVF work. So the journey is going to be beautiful. So hold on to your seats, and we are now going to take you how to do the perfect IVF cycle, starting from a small antral follicle to actually giving a live birth in the hands of the couple. So let's begin with how it all started. We know that previously we were doing, maybe about until 8 to 10 years ago, it was all about fresh embryo transfers. And if you look at this classical slide, the optimum number of oocytes at that time was considered to be between 5 and 15, peaking at about 13. That means you get best pregnancy rates, as Sankara also showed in his original classic study, that if you get 5 to 15 oocytes, you will have best take-home baby rates. Beyond 15 oocytes, the pregnancy rates actually started dropping with fresh IVF transfers. And we now know that that's because of supraphysiologic levels of estradiol, sometimes elevated progesterone, which alter the endometrial receptivity and therefore reduce pregnancy rates. So at that time, ovarian stimulation was targeted to getting 5 to 15 oocytes. Today, we now have vitrification for more than a decade now, and it's not just about fresh embryo transfer rates anymore, but in fact, it's about cumulative live birth rates. That means how many embryo transfers can you do from one single stimulation? And we now know that the more the oocytes you get, the higher number of embryos you will have for vitrification, the higher number of chances the couple will get at frozen embryo transfer, and therefore you will get a higher cumulative live birth rate. So we now know that the ideal number is no longer just 5 to 15, but is in fact 25 or maybe 20 to 25 oocytes, because until 27 oocytes, you have an increase in cumulative live birth rates, beyond which then there is a plateau. So there's no point getting 30, 40, 50 oocytes. You might have, even if you use the agonist trigger, there is always the risk of ovarian enlargement causing torsion. So your target is now at 20 to 25 oocytes. So today in 2020, when we talk of aims for controlled ovarian hyperstimulation, we know that, of course, we want it to be safe, we want it to be cost effective, we want to be very efficient and very successful, easily acceptable to patients with minimum injections. We do not want a single admission for ovarian hyperstimulation. At the same time, we want 20 to 25 oocytes, enough top quality embryos for vitrification to give us a high cumulative live birth rate. My favorite area, and one which is most neglected in a lot of clinics, is pre-treatment. Very often I see a lot of clinics, almost I would say 70 to 80% of clinics, just putting patients on the oral contraceptive pills so as to schedule their work, so as to try and ensure that every pickup and transfer falls within a stipulated time. So what do we need to be careful about when we talk of pre-treatment? The 4 common methods which we have, of course, is the use of estradiol valerate, which has always been a favorite for me until about I think a year ago, when we switched to the use of the antagonist. And luteal estradiol valerate, very easy to use, 2 milligrams twice a day from day 25. The patient will get her menstruation. So the beauty of this low dose estradiol is that, unlike a OC pill, you do not stop menstruation. You then call her in on day 1 or day 2, and maybe suppose the day 1 or day 2 happens to be a Monday. You don't want to start stimulation because egg retrieval would be on the following Sunday. You just continue the estradiol valerate, maybe for 2, 3, 4, 5, up to a maximum of 8 days, and then begin your FSH. The beauty of this is that you will get suppression of the dominant follicle because of the negative feedback of estradiol, but you will not get over suppression of endogenous FSH-LH, unlike the OC pill. You then stop this 1 day before you begin FSH. There are some new papers which say that you can continue giving it until the day of HCG also, and it in fact gives a better outcome that way. Even easier to do, norethistérone, very simple, just give it twice a day from day 20. You can give for a minimum of 7, maximum of 15, try to avoid going beyond 15 days. Then stop it on a Sunday in between the 7th and the 15th day. She will bleed on the following Thursday, and Friday you begin your stimulation. So again, you have beautiful manipulation of the cycle without over suppression of endogenous FSH LH. Now, why do I keep saying this? Because with OC pills, we know that what we have been doing is giving from day 2, and a lot of people give it for 15, 20, 30, 40, even 50 days just to schedule their IVF batch or for whatever reasons they have. And this I'll subsequently show you is not in the best interest of the patient. And what is unique now, of course, is the use of the antagonist, which I feel is the best of all these methods for programming. And when I say programming, I mean in a short antagonist protocol, our aim is to get a uniform cohort of follicles. Now, it is just not about manipulating the dates, but you also don't want one follicle to become dominant. And that is the whole idea of this programming besides manipulating dates. The best way of getting a uniform synchronous cohort of follicles, in my experience, is to give the antagonist on days 2, 3, and 4. So you just give her antagonist on day 2, 3, 4, and from day 5, you begin stimulation as usual with the FSH or HMG, and then restart antagonist when your lead follicle reaches 14 millimeters, which all of you are familiar, is the standard short antagonist protocol. And here, when you do this, you get a fantastic synchrony. Instead of, I'm sure all of you agree that with the short antagonist protocol in almost 30 or 40% of patients, if you have not done adequate pre-treatment, you will notice that one follicle races ahead of the others, and you have one of 19, the others all lagging behind at 14, 15. You have an asynchronous cohort, and you don't get a good crop of top quality embryos. Why am I against the OC pill? We have a lot of evidence now, right from way back in 2006, especially in antagonist protocols: slower follicular growth, lower estradiol levels, longer stimulation, higher consumption of REC FSH. Also in 2017, Farquhar showed lower ongoing pregnancy rate, lower live birth rate, and as recently as 2 years ago, Kolibianakis showed in a beautiful paper that you have higher miscarriage rates when you use OC pill pre-treatment for antagonist IVF cycles. So please, 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 you have a lot of other options. Just try to avoid use of OC pills. And I will also show you why it is not good, especially in high responders. What is new? We now have an oral alternative. So instead of using the agonist or the antagonist for suppressing the premature LH surge, we now have a lot of publications showing the use of progestins, especially medroxyprogesterone acetate. So you just have to give daily 10 milligrams of MPA from day 2 when you start FSH or HMG. This effectively blocks the LH surge completely. But of course, because you have given progesterone in the follicular phase, your endometrium is not going to be very receptive. So you cannot do a fresh transfer when you use MPA for suppressing the premature LH surge. So this is something new which we have. And this is a more recent paper which shows that even 4 milligrams of MPA is equally effective as 10 milligrams when you consider the number of oocytes retrieved and the pregnancy outcome after FET. So this 4 milligrams is sufficient to prevent untimely premature LH rise in patients undergoing IVF and ICSI. The next important thing when we talk of follicle to live birth, you have now done your pre-treatment, is selecting the right dose of FSH. Now remember, all of you know this slide, but it's very important to focus on each of the parameters. You have to take into consideration age, the BMI, AMH, antral follicle count, her previous response if she's done IUIs or IVFs with you or with another center, and whether she has associated endometriosis or is a severe PCOS or potential high responder. So once you put all these 6 parameters together, then you would come to the correct FSH dose. Now for normal responders, very often I find some clinics begin with 150 or even 100. We have enough evidence from this Cochrane analysis now that you get significantly more eggs when you use 200 versus 100, significantly higher with 200, even when compared to 150. then you would say, why not give 300? But there is no difference when you go from 225 to 300. So the best dose for a normal responder, normal BMI, under 35, endocrinologically normal patient, no endometriosis, no PCOS, standard ICSI case with just male factor or maybe unexplained infertility, 225 is usually the standard and the best dose for these patients. In fact, recently Blockil showed, and I'm sure he'll show it in the Fertivision lecture too, that across all groups, whether you are dealing with a poor responder, a normal responder, or a high responder, none of the patients need more than 225. In India, we have a very common practice of going up to 450, 600. It is absolutely useless. Please remember that all you need is 225 IU for most of these patients, especially normal responders, which we are talking of in this first slide. And this is the study I was trying to show you, which Blockil showed this year at the Genesis conference, that doses of more than 225 per day of REC-FSH does not increase ovarian response across all ovarian reserve categories. So you can clearly see you have the same response, 225 versus 300, whether you have a poor responder, a low AFC or a high AFC, most of them 225 should be your peak dose. Now let's start with the high responder. Now this is very important because I'm sure 30% of your patients are PCOS, and the young, thin, lean PCOS patients. You're always worried about hyperstimulation. Do you really need to worry anymore? Now, please pay attention to this slide because this category of patients has a lot of problems. One, of course, we all know for more than 20 years now that these patients will have an exaggerated follicular response. In olden days, when we had only the HCG trigger, we were worried about that. Now with the agonist trigger, probably we don't worry so much. Difficulties in titrating doses. You start off with say 200 and you say, oh my God, there are 30, 40 follicles. Let me drop to 100 or 75 or stop the FSH. So these knee-jerk reactions were common in this category. Increased risk of cancellation, either because she doesn't respond to your dose or she has hyperstimulation. Tendency to premature progesterone rise, very important. Once you cross 15 follicles, there is a 16% incidence, sometimes 20%, that the patient will have a premature rise of progesterone on the day of HCG, thereby making the endometrium unreceptive, and you cannot do a fresh embryo transfer. Poor oocyte quality. We know that PCOS patients often have mitochondrial defects in the oocytes. We know that they will give you a lot of oocytes, but maybe not of the best quality. Fewer top quality embryos, therefore, because the oocytes are not too good, and increased risk of spontaneous pregnancy loss and early miscarriage. Now, each of these things is very important because we now need a solution to stop these problems. You don't want OHSS, you don't want early miscarriages, you don't want premature rise of progesterone, you want more top quality embryos and better oocyte quality. So what do we have here? Now, of course, as far as the basic protocol goes, very easy. All your problems are now things of the past. You just have to follow the simple 3 musketeer approach for all potential high responders. It means high AMH, high AFC, PCOs, very young, lean, thin patients. So all these, okay, you will not use a long agonist protocol, but will use only the antagonist protocol. You will not use an HCG trigger if she has more than 15 or 20 follicles. You will use the agonist trigger. And because you have given the agonist trigger, the corpora lutea will be deficient, the luteal phase will be deficient, and you will need to do a freeze-all, and you cannot do a fresh transfer. So now that we have an agonist trigger, our aim is to maximize, go up to 25, 30 eggs, at the same time use the agonist and not get ovarian hyperstimulation. So what is the agonist trigger? We know that you can use 0.2 milligrams of triptorelin as the trigger, which is an agonist trigger. It has a very short half-life as compared to HCG, you can see here. And that is why it's almost like the endogenous LH FSH surge of a natural cycle, what you get. And therefore you don't get hyperstimulation, because we know that hyperstimulation only occurs because of the long half-life of HCG. Luteal phase deficiency, of course, is the problem when you use an agonist trigger, and therefore we know that you have to do freeze-all when you are doing this. Are there some lines? Okay, now this is the most important slide, which I wanted to show, especially for high responders. and why I am against giving the OC pill for these patients. Just look at this slide. If you have given the OC pill to a high responder, any PCO patients, which a lot of us have been doing for some years now, just to manipulate the cycles or make sure they get a good withdrawal bleed. And then we know that most of these patients will need the agonist trigger. But remember that for the agonist trigger to work, you need a good reserve of endogenous FSHLH which can be released. Now, if you have given her prolonged OC pill, especially more than 15 days, you will have excessive suppression of LH at the start of your stimulation. So you please see this, the higher the suppression of LH, the lower the levels of LH at the start of stimulation, the higher the chance that you will get a suboptimal response. And by this we mean that you will have 30 follicles, but you will get only 20 oocytes. You will have 20 oocytes, but only 5 M2s. You will have 5 M2s, but only 2 top quality embryos. And this is the commonest complaint that we find when people use the agonist trigger and then feel, oh, the agonist trigger is not good as the good old HCG trigger. Somehow I never got good results. The culprit is the OC pill. Also, most egg donor agencies usually put the donors on OC pills. These are categories who are likely to be high responders. We don't want a hyperstimulation in an egg donor. So we invariably use the agonist trigger and then find, oh, my patients give me very good proportion of metaphase 2s, but the egg donors with the same agonist trigger are not giving me a good crop. And this is the reason. And that is why it's such a beautiful slide and very important slide to remember that please do not use OC pill pre-treatment for any category of patient, because I showed you even in the, especially in antagonist protocols, in agonist, anyway, you don't need to give OC pills, but in antagonist, as commonly practiced, you have other options for programming, scheduling, and getting uniform cohorts. Then came some papers that why not add back HCG with the agonist trigger and go ahead with a fresh embryo transfer. So here you can see that when you do add back HCG, you will get back good pregnancy rates of almost 50% per cycle, like your normal other patients, but you still have an unacceptably high incidence of hyperstimulation at around almost 14 to 15%, which to my mind in today's IVF practice is unacceptable, because we know that to be a good IVF clinic, you need to be OHSS free clinic. So although there are some papers that say add back HCG could be used with the agonist trigger to do a fresh embryo transfer, yes, you get a good pregnancy rate, but this 15% is still unacceptable. So I stick and adhere to the 3 musketeer, that is the antagonist protocol, agonist trigger, and freeze all policy. Does freeze all really work? And you can see here that especially when progesterone levels are high on the day of HCG trigger, you can see when you do a freeze all, you have much higher pregnancy rates than if you were to do a fresh embryo transfer in these patients. So we have enough papers now published to show that freeze all is much better, especially if there are more than 15 follicles, more than 15 oocytes retrieved, and you should not do fresh transfer for such patients. And our own experience way back about 5 years ago, when we shifted to the 3 musketeer approach, you can see here 127 patients of PCO. At that time, we were giving 150. Now we've switched to almost 200 because we want more oocytes. We now know that the agonist trigger is very safe, even if you have 25, 30 oocytes. All of them got the agonist trigger. All had vitrification on day 2, and all had a thaw transfer at the 8-cell stage in an agonist down-regulated and estrogen progesterone primed cycle. And as expected, excellent 60% positive pregnancy rate in the first frozen transfer. Early miscarriages, ectopic pregnancies were much lower than the fresh transfer group, and a take-home baby rates close to 50% in this otherwise very difficult category of patients to treat. So treating a severe PCOS is now too easy and too simplified with this simple approach, as long as you have a good vitrification program. A lot of us try to reduce doses on day 7, thinking that this is going to help. And you start with 225 or 300, then on day 7, you see, oh my God, she's got 40 follicles, she'll get hyperstimulated. Let me come down to 100 or 150. Is this really going to work? If you look at basic physiology, and it's again a very nice slide, you can see here, even if you reduce the dose on say day 7, you will see that it takes 3 to 4 days. Even if you discontinue the FSH completely, it takes 3 days for the FSH concentration to fall below the threshold. Now, what is the threshold? The threshold is the level at which you keep recruiting new follicles. So you will see here that although you stopped at day 7 or reduce the dose here, you keep recruiting new follicles for a further 3 days until day 10. So this is the problem, that these knee-jerk reaction decreases in doses are not going to work. So just stick to your original dose and make sure that you give the agonist trigger. Don't worry, even if she has 30, 40, 50 oocytes, she is not going to get hyperstimulated as long as you use the agonist trigger. So you can see here again that what are the effects and implications of dose reduction. Suppose I do it on day 7. If I maintain 225 or 150, or if I stop the dose, you can see here follicular stimulation goes on continuing for another 5 to 6 days. So whatever you do at this stage doesn't really stop or prevent ovarian hyperstimulation. Now, this is the biggest advance we have had this year, and that is, until now, we've been taught that in PCO patients, you do not have to give LH. They already have high LH. They just need pure FSH. And which is why 20, 30 years ago, when we were first using just HMG, we then got purified FSH for the PCO groups, then highly purified, then REC FSH, then long-acting REC FSH, and all of us started using FSH for PCO. This now is a revolutionary trial which is recently published, and that's the Megaset HR trial, where they have used HMG in antagonist cycles in high responders in PCO patients. And that is why I told you to pay attention to each of those points, that what are the trouble areas when you are treating high responders. And you can see here, they compared the use of HP-HMG versus REC-FSH. And you can see here that the estradiol levels twice as much higher as compared to HMG on day 6, which is expected, which is why you get more hyperstimulation with the use of REC-FSH. You can see here ongoing pregnancy rates in fresh transfers, HP-HMG marginally better than REC-FSH, although it did not reach statistical significance. Live birth rate per transfer again was better with HP-HMG. Significantly, early pregnancy losses were lower with the use of HP-HMG. Now, this is a very important point, because that was one of the points in the first slide, that early miscarriages is always been a problem with PCO and high responders. And again, if you look at this very interesting study here, you get 7 less oocytes when you use HP-HMG. Now, most of you would think that that's a disadvantage. How can you say HP-HMG is better if you're getting 7 less oocytes? But it's just 7 less oocytes, which translates into 5 less metaphase 2 oocytes, which then translates into 4 less zygotes at the 2PN stage, 3 less blastocysts on day 5. Now, by now, all of you are convinced that REC-FSH is better because it is giving you more oocytes, more embryos, more blastocysts. But when you look at top quality blastocysts, it is the same. So despite getting 7 more eggs in the REC-FSH arm, ultimately you end up with the same number of excellent blastocysts, which are finally going to give you the take-home baby on day 5. So this is a very important subject which the trial has now established, that HP-HMG might be better than REC-FSH even in PCOS and high responders. What about frozen transfers in these patients? Again, you can see live birth rate with frozen transfers higher in the HP-HMG arm. Cumulative early pregnancy loss is much lower. Fresh and frozen also much lower with HP-HMG. And again, cumulative live birth rate, if you to put all the frozen transfers together, finally, they both are the same at around 50%. But the cumulative live birth rate in the HP-HMG group is achieved with fewer transfers. So they had to do 43 less transfer procedures, and they had transferred 65 less embryos in the HP-HMG arm to get the same cumulative live birth rate. So the main advantages here, of course, what the trial did establish: significantly lower hyperstimulation with HP-HMG, reduced early miscarriages, and non-inferiority as far as pregnancy rates and cumulative live birth rates are concerned. So we now know that we need to again rethink, again go back to using LH for high responders as well. And you can see here comparable live birth rates, just to summarize what I already told you, with fewer transfers, lower number of transferred embryos. The higher ovarian response with REC-FSH did not confer any clinical benefit as far as pregnancy rates were concerned, and in fact was associated with higher OHSS. Main important advantage: reduce early pregnancy loss rates in both fresh and frozen cycles with HP-HMG. So this is a very important new advance that all of us need to take into consideration. Of course, we finished normal responders and high responders. But the commonest category, I'm sure all of you agree that 4 out of 10 or 5 out of 10 patients nowadays have low AMH, low AFC, and are potential poor responders. Very easy to treat if you remember three basic principles. There are three types of poor responders. One is the patient who has a reduced number of FSH sensitive follicles. So you know that the patient is starting with a low AMH and low AFC. She will be a poor responder, no surprises there. The second patient, she had adequate follicles, but you gave her a reduced inadequate dose than what she actually required. So suboptimal exposure to gonadotropins is the second category of poor responders, which is more iatrogenic because you miscalculated. And the third is your dose was correct. She had enough follicles, but yet she did not give you the ideal response because she is carrying FSH and LH receptor polymorphisms, which is why the ovaries are less sensitive to exogenous gonadotropins. And that brings us, of course, to the four groups. Group 1 and 2 are young and old patients with a normal ovarian reserve. So they started off with normal ovarian reserve, but they did not give you a good response. So group 1A gave you just less than 4 eggs. Group 1B gave you just about 4 to 9, as against the expected 15 to 20 follicles in these two patients. So group 1 and 2 are the unexpected poor responders. Group 3 and 4 are the young and old patients with a reduced ovarian reserve to start with, and therefore they have an expected poor response. And together they constitute almost 50% of patients in most IVF clinics the world over. So let's begin with groups 1 and 2, which is the difficult group. And as I told you, most of these may be because of inadequate dosing, some of them because of polymorphisms, but the commonest in my experience problem is inadequate pre-treatment, which is why you had follicular asynchrony or dominance, which in simple terms means that maybe you started on day 2 evening or day 3 or day 4 even, when the dominant follicle was already selected. So even as much of exogenous FSH you pump in, you are a day or two late, which is why that one follicle will grow ahead of the others, and you will not get too many oocytes or too many good quality embryos in these patients. And which is why, again, I emphasize that pre-treatment is so important for these patients. So your plan should be antagonist cycle. If you're using, then use adequate pre-treatment. The best is cetrorelix on day 2, 3, 4, and then begin stimulation from day 5. My personal favorite for a lot of poor responders is to use the long protocol. And a lot of you would say, what is he saying? Long protocol will cause oversuppression and further reduce the response in these patients. It's quite to the contrary, as I'll show you a lot of evidence, that in fact, the agonist makes sure that you get a more uniform cohort. Any of you who have used both the protocols in plenty will always remember that with the agonist protocol, you got more follicles, more oocytes, and uniform growth of follicles. Now that would of course cause hyperstimulation in high responders, but now we are talking of poor responders. And isn't that what we want? We want more oocytes and we want a uniform cohort, because we know we are going to get only 5, 7, 9 oocytes, and we want to get 5, 7 or 9 good quality embryos. Of course, if you started with a less dose, then in the subsequent cycle, you can increase the dose, and you could use LH or HMG instead of FSH. Again, in this category too, a little bit of LH, as a lot of studies have shown, is always useful for poor responders. So this is what the antagonist pre-treatment does. You can see here, when you give it on day 2, 3, and 4, you can see you get significantly higher number of oocytes in the treated group as compared to the control group. So this was statistically significant, and in poor responders, even 1, 2, 3 more oocytes are always welcome and very important. There are some patients where you have elevated progesterone before the start, and this is a neglected area. All of us know that, okay, we have to check progesterone on the day of HCG, but we now know that we have to also check progesterone on the day of starting stimulation, that is day 2. And you will find a lot of patients would have high progesterone because of a residual corpus luteum cyst or whatever we have. And in these patients, if you don't treat it, you have very low implantation rates as compared to the normal progesterone group. This was known to us way back in 2004. And Blockil in 2011 showed that administering the antagonist again on days 2, 3, 4 in this group, and you will reduce the progesterone levels after 3 days of antagonist. From 3.3, it comes down to 0.8. You then begin stimulation from day 5, and you restore your same ongoing pregnancy rates. You can see here statistical no difference between the high progesterone group and the normal progesterone group with simple 3 days of pre-treatment for these patients. Again, in poor responders, it goes the other way. We try to increase the doses on day 7. So you started with 150 or 225, expecting her to be a good responder. Day 7, you see only 3 follicles. You say, oh, I need to give her 450. And then you psychologically expect that you will get more oocytes. Again, the same logic. Day 7, scan decision point. And you can see here, even if you increase the dose, remember that the follicles which have already been recruited have already grown to a size of say 12 to 13 millimeters. You are now increasing the dose here in the hope of getting more follicles, but this will again take 3 to 5 days for new recruitment to begin. As you can see here, new recruitment begins after 3 days of your increase in the dose. But by that time, these follicles are already 16, 17 millimeters and you are ready for the trigger. So these newly recruited follicles are not going to give you any mature oocytes. So again, remember, correct deciding of the starting dose is the most important. You cannot change doses on day 7, day 10 and expect to get more oocytes in these patients. So this is unlikely to influence the response outcome, any change in dose after day 7. What about agonist versus the antagonist? And this is again very important because until now everybody thinks agonist causes over suppression. It is not to be given for poor responders. You must use only the short antagonist protocol. As I told you, uniform synchrony of cohort is the most important factor, and that goes wrong in a lot of antagonist cycles if you have not given adequate pretreatment. And here we have, of course, agonist versus antagonist. You can see antagonist group, agonist group, more than 500 patients in both the arms. Number of oocytes, number of embryos, pregnancy rates, live birth rates, all significantly higher with the agonist as compared to the antagonist. So we really need to rethink whether we should just be blindly using the antagonist. And of course, doing it yourself is always the best. And we did a short trial, a very unique trial in that the patient herself was a control for the trial. So to explain it easily, we did in the same patient one cycle of the conventional antagonist with a combination of REC, FSH, and HP, HMG. Of course, at that time, we were still using doses of 450. Now we've come down to maybe 225 or 300 max, and compared that with the agonist. But here we used HP, HMG 300. And you can see clearly you get significantly higher number of oocytes with the agonist and HMG protocol in poor responders. These were all, mind you, young patients, mostly 30 to 36, AMH of less than 2, and 50% of them even AMH less than 1. And you can clearly see you have a tremendously higher percentage of top quality embryos in the agonist group as compared to the antagonist group. So 30% of the embryos were top quality in the agonist group as against 17.5%. And again, you get much more of poor quality embryos with the antagonist as compared to the agonist. Next, moving on to the dose. How high should you go with your FSH dose? And this is very interesting because we see in India that a lot of overdosing happens for poor responders. Please remember that if you had given 150 in the first cycle and you got 5 oocytes, you don't need to go to 450 in the next cycle expecting 20 oocytes. All you need to do is increase by just 50 to 75 IU. And as you can see here, even increasing the dose just from say 200 to 250 to 275, and you can clearly see you have a tremendous increase in the number of oocytes that you will you can see here from 200, if you go to 275, you only increase by 75 IU, you have a definite increase in the number of oocytes that you get. So for groups 1 and 2, where you underdosed, all you need to do is increase by 75 in the next cycle, and you will get significantly higher number of oocytes. Now, a lot of you would feel, why is he talking of getting 6 instead of 5 oocytes? Does it really make a difference? Yes, for a poor responder, you can see with every additional oocyte that you get, there is an increase in the live birth rate per cycle. So with one oocyte, you are at say 4%, 2 oocytes goes up to 9, then 12.5, 16.7, 22. So you can see with each additional oocyte, there is a definite increase in the pregnancy rate per cycle. So that was group 1 and 2, where you could increase the dose by 75, you could give good pre-treatment, or you could use the agonist with HMG and expect a better response in the next cycle. What about 3 and 4? Now, these are young and old patients who are starting with a very poor ovarian reserve. Now, remember, these patients in these women, giving her higher doses will not compensate for this absence of follicles. So you cannot do anything for these patients by just stepping up your FSH doses. And what they actually need so here again, you can see that what they actually, where is this marks? Yeah. So here you can see what are the treatment options available to you. You know that she doesn't have follicles. Again, I would stress that the agonist would do better than the antagonist purely for giving you a better uniformity of the cohort. Maybe HMG could be better than FSH. Now we have enough of evidence to show that a lot of group 3 and 4 have androgen deficiencies, which is why they don't respond well. So giving them LH from the beginning definitely helps. Embryo accumulation, don't transfer. If you have just one medium quality embryo, don't do a transfer, because what really affects the patient is having a negative beta hCG test. So if you really want to optimize her treatment outcome, you just accumulate embryos. So you do 1 or 2 or 3 rounds of ovarian stimulation, use different protocols as per your choice, accumulate till you have 2, preferably 3 top quality grade 1 pure embryos, and then do a good frozen embryo transfer. PGTA, of course, still a bit controversial. What I'm really excited about is dual stimulation, which is really working wonders for a lot of these poor AMH group patients who are not ready for oocyte donation. So you have to persist, and this seems to give a lot of rays of hope for these patients, and that is dual stimulation. We'll come to that in a short while. So you can see here again, agonist versus antagonist. Study in group 3, that is young patients with a diminished ovarian reserve, one of the commonest categories all of us are being seeing nowadays, 28-year-old, 32-year-old, AMH 0.6, 1, and so on. Again, the agonist cycle gives you almost double the pregnancy rate in these difficult patients as compared to the antagonist. What about how high should you go with your FSH dose? Should you go 300? Should you give 450? Should you give 600? And as this study beautifully showed, there is no difference in live birth rate with these doses. So you don't really need to go too high. They don't have follicles, so giving them too much of FSH doesn't work. In fact, maybe just 150 is enough for groups 3 and 4. So you remember that you are expecting only 3 or 4 follicles. 150 IU is sufficient to expect a good growth of those 3 or 4 follicles. So this is quite contrary to what everyone practices, that don't just step up doses. In fact, very high doses of FSH can cause zona pellucida damage. And often your embryologist will tell you fragile oocytes and the zona is just breaking. That's very commonly because of very high doses of FSH being given to that patient. And this is the dual stimulation. Until now, we were all familiar with follicular phase stimulation. You start stimulation on day 2, do the retrieval on day 12, then wait for a menstruation and start the next cycle. We now know that 1 in 3 women have 3 waves of follicular recruitment in a single menstrual cycle. And 2 in 3 women have at least 2 waves. So this is very important, that we now know that we can not only stimulate the follicular phase, but we can also stimulate in the luteal phase and again do a second retrieval in the same month. A lot of you would argue, what is the logic? Why do you want to be in a hurry? There will be so many corpora lutea, there will be cysts. How do you know which is a new follicle? What about the endometrium? She will get her menstruation when you're doing the second retrieval. Yes, all that might happen, but there is some key findings behind this. And this was the original study by Ubaldi, 51 patients who did the dual stimulation. How it is to be done? Very easy. He used a combination of REC FSH, REC LH. I use HPHMG, 300 plus 150. I don't go about 225 or 300 from day 2. Then the antagonist as usual. Then agonist trigger. The trick is you cannot give HCG trigger because HCG will have a long half-life and your corpora lutea will interfere with the second round. So just give an agonist trigger, do the egg retrieval as usual, wait for 2-3 days and again start the REC FSH, REC LH, again antagonist when the follicles reach 14 mm, again the agonist trigger and again a second retrieval. And the whole beauty of this dual stimulation is that the luteal phase often gives better quality oocytes and embryos. And I've done about 60 or 70 patients now. And in 70% of patients, the luteal phase is almost like a miraculous dramatic difference from the follicular phase. So just last week, we had a patient follicular phase stimulation, AMH was 0.3. She gave just 1 oocyte as expected. luteal phase stimulation with just 225 of HMG, she had 7 follicles and 3 top quality embryos. So this is the kind of difference we are seeing. And of course, this was the original paper, that the rate of patients obtaining at least one euploid blastocyst increased from 42 to 66% when you add luteal phase stimulation. So remember that conventional antagonist stimulation does not take full advantage of the whole follicular cohort. And this is what we want in a poor responder. We want the entire cohort to be extracted and taken out. So statistically significant, better embryos in the luteal phase. Moving on then to the trigger. Very important, often neglected. Very commonly you get more follicles and less oocytes. Sometimes you get more oocytes but less metaphase 2 oocytes. Sometimes you have adequate metaphase 2 oocytes but less top quality embryos. And this, of course, one of the reasons is, as I told you earlier, the OC pill pre-treatment. But remember that what is the logic or the rationale of using a dual trigger? We know that when we give HCG, it stimulates only the LH peak. It simulates the LH peak binding with the LH receptors, but does not have any FSH activity. But if you look at a natural menstrual cycle, final oocyte maturation is induced by an increase of both LH and FSH. So this is very important. And we know that when you use an agonist trigger, you induce a more physiological peak by displacing the antagonist and inducing both LH and FSH flares or surges, which gives you a better conversion of the response and the final outcome. So you can see here patients where you had low number of oocytes retrieved compared to the number of follicles. The minute the dual trigger was used, there was more than a doubling of the number of oocytes retrieved in these patients. What about getting low proportion of metaphase 2 oocytes? Again, when you use a double trigger, you can see number of metaphase 2 oocytes up from 3.6 to 6.5, again almost doubling to what you were expecting in the beginning. So there are a lot of these patients, especially poor responders, where every egg is going to make a difference. It is important to use the dual trigger. And here is a study from 2019 for poor responders. You can see the study group, that is combination of HCG with 0.2 milligram agonist, and you have significantly higher clinical pregnancy rates, live birth rates, abortion rates are lower, and ET cancellation rates are lower when you use a dual trigger for these patients. Monitoring, just keep it very simple. You don't need too much of hormone estimations. TVS usually on day 2, day 7, and day 10 suffices. Estradiol estimations are never required unless there is a residual ovarian cyst. Again, there I directly prefer to give the antagonist for 3 days rather than put her through one more serum estimation. Serum progesterone, day 2, ideal. As I showed you, there are a lot of patients who have high progesterone on day 2. Day of HCG, only if you are contemplating a fresh embryo transfer for that patient. You want to make sure your progesterone is between 0.5 and 1.5. Anything less than 0.5 or more than 1.5, you would rather do a frozen transfer. And nowadays, it is recommended to do a progesterone level on the day of transfer or a day before in a FET cycle. Why do we need luteal phase support? Of course, this is a very basic question. We know that when you use GnRH analogs to prevent the LH surge, you suppress the luteal phase, and also when you aspirate a lot of granulosa cells during oocyte retrieval, you impair the corpus luteum's ability to produce sufficient progesterone. This in turn causes you a short luteal phase. You can see a gap of almost 5 to 6 days. You have a very short luteal phase and early menstruation if you do not support the luteal phase in these cycles. Does it affect both agonist and antagonist cycles? Yes, we know in agonist cycles, we knew way back in 87, 88 that you have to give luteal phase support because the agonist will cause prolonged blockage of pituitary gonadotropin release during the luteal phase. And classic study by Beckers in 2000, again, where he used HCG as luteal support, early cessation of agonist without luteal support, long use of agonist without luteal support, and you can see without support, very short luteal phases, just 8 to 10 days, early menstruation, and almost negligible pregnancy rates. Then they thought that, okay, maybe the agonist causes oversuppression, and when we use antagonist protocols, maybe the luteal phase will be the best and will not require support. But again, this study, you can see when he compared using the HCG trigger versus REC-LH versus the agonist trigger, in antagonist cycles, again, dismally low pregnancy rates in all three categories, establishing once again that your luteal phase deficiency is probably related to the negative feedback from the high estradiol levels, which are from multiple follicles, and that is what causes the luteal phase deficiency. So we need to support in all the three groups. So we know now that, of course, in stimulated IVF cycles, you have a higher number of corpora lutea, which release a lot of high levels of estrogen progesterone, which give a negative feedback, which inhibits LH release and causes your luteal phase defect. What is the current consensus that what should we be using for luteal phase support? We know both progesterone and HCG are associated with higher rates of live births. So of course, progesterone and HCG support have been the most popular. Addition of the agonist is associated with an improvement in pregnancy outcomes in the luteal phase. Hyperstimulation rates are more with HCG, so it is no longer too popular. Addition of estrogen does not seem to improve outcomes. So this huge Cochrane analysis 2015, and a lot of people still keep giving estrogen in the luteal phase for reasons best known to them and is just not required. Route of progesterone administration does not alter the outcome. So whether you use intramuscular, vaginal, subcute, all should give you probably the same results. When to start luteal phase support? I prefer to start from the day of egg retrieval if I'm doing a fresh embryo transfer. And you can see here this study from 2018, where he compared two groups. Group A, where luteal phase support was started one day after egg retrieval. Group B, it was started on the day of retrieval. And clearly there is no difference in the pregnancy rate. So the current consensus is you can start on day of retrieval or a day after, but not later than 3 days after the egg retrieval process has been done. What are the available options? We all have been using progesterone. In fact, 75% of the world still uses progesterone micronized as the best progesterone luteal phase support. HCG was popular in the past, but we know that it increases the risk of hyperstimulation. And some people like to add small doses of agonist in the luteal phase to get LH surges, which would continue to support the corpora lutea. Ideal doses, of course, intramuscular progesterone, I prefer 50 if I'm using fresh transfers, 100 mg if I'm doing a frozen transfer. We also have been very familiar with progesterone gel if it is a fresh cycle, 90 milligrams once a day. If it is a replacement frozen cycle, then 90 milligrams twice a day, and so on. And now we have a lot of evidence to show that oral dydrogesterone is probably as equally effective as micronized vaginal progesterone and has the greatest advantages of being the oral route, which is preferred by most patients, and also having immunomodulatory effects and reducing miscarriage rates. So of course, we know that with oral progesterone, there is low bioavailability. With vaginal, sometimes there is side effects like irritation and not very popular, but patients do it if they don't have an option. Intramuscular, excellent success rates, but very painful. Oral dydrogesterone has all the advantages of being oral route, equally effective, same success rates, and reduced miscarriage rates, as Grisinger showed in 2018. And do we have evidence for this? Of course, we know that dydrogesterone is highly selective, binds exclusively to the progesterone receptor, requires 10 to 20 times lower dose for endometrial proliferation, and has a very good safety profile for both the mother and the child. It also has the added advantages of being immunomodulatory, and that gives you a good advantage in threatened abortion patients. And then, of course, we had the Lotus 1 trial, which established non-inferiority of oral dydrogesterone over micronized vaginal progesterone capsules. And then we had Lotus 2 trial, which showed that it is as effective as the gel as well. So of course, now we know that in any fresh cycle IVF, mark the words, wherever in any cycle, whether it is OI, it is IUI, or it is a fresh IVF cycle where you have a functioning corpus luteum, oral dydrogesterone is equally effective as microvaginal progesterone. We still don't have all the data for frozen embryo transfer cycles where you don't have a functioning corpus luteum because you've done either an agonist downregulation or your exogenous estradiol progesterone is having a negative feedback and inhibiting ovulation. So in those patients, we feel that maybe 40 milligrams should be the ideal dose, but we are waiting for a few more studies to establish that. Safety profile, of course, very important slide. We know that dydrogesterone has been used since 1960s. Probably more than 113 million women have already taken it over the past 30, 40 years, 50 years. It is estimated that more than 20 million pregnancies were exposed to dydrogesterone, and we now know that it is absolutely safe as well as maternal and fetal and the child safety is concerned. And it has also been approved for luteal phase support in ART, first in the Netherlands on 2017. When to discontinue luteal phase support? Very interesting here. We all know basic physiology from way back in 1991, that the luteal placental shift occurs at 6 to 7 or maybe 7.5 weeks. And yet we all love to give micronized vaginal progesterone until 12 weeks of pregnancy. So we need some more data on this. Of course, there are papers which say better to be safe than sorry. And as you see, this huge worldwide survey showed that majority of the world, 80%, 90%, 100%, 60%, 80% as per the country and continent, continue luteal phase until 10 to 12 weeks of gestation. So we need to reassess and reevaluate this, because excessive medication is always avoidable. And maybe, as you can see, only 22% of the world clinics stop when they see the cardiac activity, 12% only stop when beta HCG is positive. So it's an interesting area to do some more research and find out when exactly we should stop luteal phase supports. Of course, my favorites for IUI, vaginal progesterone 200 BID or dydrogesterone BID. For fresh transfers, as I already told you, 50 milligrams or once a day gel or dydrogesterone 30 milligrams. Frozen transfers, either gel twice a day or 100 milligrams intramuscular or 400 BD of micronized or dydrogesterone. I feel 40 milligrams would be an adequate supplementation as against 30 milligrams. So of course, for luteal phase, we know progesterone is important. In both agonist and antagonist cycles, there is still a controversy regarding stopping of luteal phase. Vaginal progesterone is worldwide the most used luteal phase support, and oral dydrogesterone is as effective as micronized vaginal progesterone. Finally, of course, we have to move on to achieve your live birth. You have done the follicle, you've got your egg, you've got your top quality embryo, but you now have to transfer it and make sure you give the baby the live birth. We know that despite all the advances that we have in the lab, in the culture media, in the machines, in the personnel, in everything that has happened in the past 20, 30 years, the fact is that still 65% of IVF cycles with fresh transfer do not yield a live birth. And that brings us to the burning question whether to do fresh transfer or do a freeze-all for all patients. And you can see, to corroborate that, if you see, look at the SART data, for most of the indications, live births per cycle with fresh transfer struggling around 25 to 35% all over the years. We know that these reduced pregnancy rates are because of an asynchronous endometrium, which in turn is because of supraphysiologic estradiol levels go very high, and especially in high responders beyond 15 follicles, as I showed you in the first slide of the presentation, you might have elevated progesterone levels as well, and that causes advancement of the endometrium and makes it unreceptive for a fresh transfer. We also know that with fresh transfer, you have a higher incidence of early pregnancy losses and ectopics, higher incidence of preterm labor, biochemical pregnancies, poorer obstetric outcomes, and you still have the danger of pregnancy-induced hyperstimulation. And that brought about the question of freeze-all, that is, you freeze all the embryos, not just the second best, and then transfer them in a subsequent cycle. So how often do progesterone levels on day of HCG rise? And you can see here, if there are more than 18 oocytes, in almost 15 to 20% of cycles, you will get premature progesterone rise in these patients. You can see here, this happens in both agonist as well as antagonist protocols. The minute the progesterone goes above 1.5, there is a drastic drop in clinical pregnancy rates in both the types of protocols that we commonly use. The more the number of days over which progesterone has elevated before the day of HCG, the lower the pregnancy rates will be. You can see if there's 3 days, it drops to 20% from almost 42%. What about low progesterone? Totally neglected area. Very few people consider low progesterone, but even less than 0.5 causes a drastic reduction in live birth rates. So you need to be aware of both these categories, where freeze-all definitely works better. And you can see here, totally, if you put low progesterone and high progesterone patients together, they constitute almost 20% of all patients in an IVF practice. Does high progesterone on day of HCG affect oocytes, or does it affect the endometrium? The best way to find out is in a donor oocyte program. Donors where the progesterone was less, donors where the progesterone was high, but in the recipients, the pregnancy rates were the same. So obviously, most of the data we have shows that the embryo quality is not affected. It is only endometrial receptivity which is affected with high progesterone. But recently, we have a study that with very high progesterone, especially 2 or 2.5, there is a drop in the number of top quality embryos that you will get. And we need to be aware of that for very high progesterone levels. Any other indications for freeze-all? Yes, I told you embryo accumulation in poor responders. And this was our initial study, 2 to 3 cycles with embryo accumulation, vitrification and pooling until you have 3 top quality embryos. And you can clearly see we had 22.9%, which is of course a difficult category. So it was reasonably good as compared to the less than 10% which you normally get. And this is, you can see, initially we used to use combination of rec FSH, rec LH, 2 cycles, and ongoing pregnancy rates 23%. Then we switched to a combination of rec FSH with HPHMG, and the pregnancy rates increased to around 35% with 2 cycles of stimulation and embryo accumulation. So definitely this is a good indication for freeze-all. Then why does HPHMG give better outcomes in poor responders? And now we know, even with the megaset HR, that maybe even in high responders, you can see the higher the level of HCG, because HCG has a very long half-life. So it tends to accumulate. If you give HCG daily from day 2 of stimulation, there will be more and more accumulation of HCG. And the higher the level of HCG on the day of HCG, on day 6, you can see greater is the proportion of top quality embryos that you get. And that also converts into live birth rates. You can see here, when you look at LH, it does not accumulate. So there is no change in live birth rates, irrespective of LH levels on day 6. But when you look at HCG on day 6, the higher the HCG level on day 6, the higher is your live birth rate. So this is a very important slide, that because of its accumulation, it is probably better than native LH and regular HMG, which contains native LH, as compared to HPHMG, which contains HCG driven LH activity. What about endometriosis? Again, frozen transfer is much better and gives you better pregnancy rates. This is common knowledge that you always prefer frozen transfer in endometriosis rather than doing fresh embryo transfer. Then patients with thin endometrium, you want to work on the endometrium with your high dose estradiols and GCSF and PRP. And you know that to do that, you need time. And the best way you can do that is in a frozen transfer cycle, where you have 20-25 days after down regulation to work on the endometrium. So of course, these all are the options that you, as per your personal choice, whatever you believe in. GCSF, PRP, all still we don't have enough of data to firmly establish that they are useful, but they don't do any harm. So a lot of us have been using these modalities for a long time. Very often in the follicular phase, you find that there is a polyp that you had missed earlier, and she's due for egg retrieval. You don't need to panic. You just do a freeze-all, do a hysteroscopy with the egg retrieval, do a transfer, immediate cycle, and you will get back the same pregnancy rate as you would have got in your regular group. So doing a hysteroscopy for a polyp or a septum, you don't need to wait 2-3 months for transfer. You can do a transfer in the immediate next cycle and get excellent pregnancy rates with freeze-all in these patients too. So to freeze-all indications, low or high progesterone, patients who have had previous biochemical pregnancies or early pregnancy losses, patients who have had previous ectopics. With fresh transfer, somehow with frozen transfer, you get less of biochemicals, less of early pregnancy losses, and less of ectopic pregnancies. Poor responders, endometriosis, when you need to do PGD, of course, you need to do freeze-all. Detecting a polyp inadvertently, high responders, of course, the 3 musketeer approach, thin endometrium, and patients with repeated IVF failures. So these are all the categories who do better with freeze-all rather than fresh transfers. So we know there are a lot of reduced risks with freeze-all as compared to fresh embryo transfer. There were a couple of reports that you get heavier babies with frozen transfer or more of placenta accreta, but they're just 2 papers. I've been doing freeze-all for almost 5 to 6 years now, and we have not noticed, at least we had only 2 cases of accreta, and both were surrogate mothers with 2 previous cesarean sections. So maybe that's a high risk group, but otherwise in the normal infertility population, we don't notice this. Macrosomia, there are recent papers which say that the difference in weight is just 200 grams. So it's not really a major kind of complication. What about the effects of vitrification? This huge study, 2016, fresh transfer, frozen transfer, no difference in malformation rates. So it's pretty safe to do vitrification and frozen transfers. And the reason we switched is, you can see FET, excellent pregnancy rates month after month. This was through 2018 and even in 2019 at 53-54% with freeze-all at our clinic. The only concern with freeze-all, genuine concern, is that there is a higher risk of PIH, pregnancy-induced hypertension, for some reason. And we know the reason too, because when you do an artificial cycle, and that is why a corpus luteum is so important. And we know, is there an association between the preparation method and the occurrence of PIH and accreta? And this classic study here showed increased risk of PIH when you don't have a corpus luteum. So this was classic study reported in 2019, and you can see higher risk of PIH at 12.8% as against 4% in natural cycle transfer procedures. So this is an important area where we now need to focus how to reduce this risk if we are doing a freeze-all cycle. So this is our conventional protocol, what we've been following until last year, where we give the agonist depot, then wait for a menstruation. Day 4, begin estradiol valerate with your aspirin, sildenafil. Assess on day 14. If inadequate, continue. Assess on day 21. Then do your intrauterine GCSF or PRP. Then assess on day 25. Don't go beyond day 25. Start progesterone and plan your transfer. Give 1 day more progesterone than the stage of the embryo. So if you're transferring a day 3 embryo, you should give 4 days of progesterone. If it's a blastocyst, then 6 days of progesterone, and so on. But now we have data that you don't need to give the agonist. So they compared a huge number of patients with the agonist and just estrogen progesterone, and they found just a less than 2% incidence of premature LH surge if you have not given the agonist. So it's really, really small and doesn't justify giving the agonist depot to so many patients. So we now are discontinuing the use of the agonist depot. Also, be very careful about how many days of estradiol you give. So do not exceed 28 days before you start the progesterone, because your live birth rates will reduce. Also, if you have given more than 35 days of estradiol before you start progesterone, your early pregnancy loss rates are significantly increased. So the ideal number, that's why I showed you that around 25 days seems to be okay. Don't go beyond that with the estradiol. How many days of progesterone required? Classic study again by Blockhill, comparing 3 days versus 5 days of progesterone for a day 3 embryo. I don't know why he did not consider 4 days, which is what I commonly practice. And you can see here the 3-day group doesn't do too well because it's too less a duration of progesterone, and you can see higher risk of early miscarriages with 3 days progesterone. So it's best to give 4 or even 5 days, where you get better outcomes with a few extra couple of days of progesterone. And then he compared for a blastocyst 5 days versus 7 days. Here, surprisingly, the 5-day group did better. So you can see the 5 day of progesterone was somehow better for a blastocyst, although the final early pregnancy loss rate was the same. And then we had a study doing exactly what I've been doing all these years, comparing 6 days versus 7 days, and clearly the live birth rates are the same. So ideally, I think it's very easy to calculate also, just 1 day more of progesterone than the stage of the embryo, and usually it works. A lot of initial papers said that there is no difference between natural cycle, HRT cycle, with agonist cycle, and so on and so forth. And therefore, everybody switched to the artificial estrogen progesterone preparation. But we now have a lot of rethink about natural cycle FETs. And you can see with natural cycle FET, you have a reduction in the cesarean rate is significantly lower. Pregnancy rates are significantly higher with natural cycle FET. Also, the odds ratio, there is a 1.7 times higher risk of LSCS with hormone replacement versus natural cycle, 1.5 times higher risk of PIH, and 7 times higher risk of placenta accreta. So we need to rethink. Of course, natural cycle is not as easy to do. You have to monitor the follicle, time the rupture, and then make sure that your stage of the embryo is as per her exact date of ovulation and so on. But with practice, it's quite easy to do. And even in PCOS, you would say then if they're anovulatory patients, how would you do a natural cycle transfer? So here what you need to do is mild ovarian stimulation. Just give 37.5 or 75 to get just 1 or 2 follicles. Trigger it with HCG, and then do the transfer. And again, outcomes are much better than the artificial cycle as shown in this paper from 2018. Should you do the transfer in the immediate month after the egg retrieval, or give a 1 month break in between, as a lot of clinics do? You would wonder why I'm showing this slide, but immediate transfer somehow gives much better outcomes in terms of pregnancy rates, lower miscarriages, and so on. We still don't know the physiology for this. Maybe some of the residual hormones have a good effect, but probably it's better to do an immediate transfer rather than delay it by a month or 2. Am I giving you a message to do freeze-all for all? No, I am not. We just outlined all the indications. So there is a chunk of patients who are normal responders. And as this study clearly showed, that if you have less than 10 oocytes, you can see here, if you have 1 to 3, freeze and freeze-all and fresh is same. 4 to 9 oocytes, same. But if you have 10 to 15 oocytes, then freeze-all is better and gives you higher pregnancy rates. There are a lot of publications after this one in 2017, and maybe 13 is the lucky number at which you cut off. So less than 13, you can do a fresh transfer. More than 13, you do a frozen transfer. And this was the study which proved that in normal responders, the results are the same, and you don't really need to add the expenses of vitrification and the lab pressures for doing freeze-all for these patients. So many advantages in performing a freeze-all. but not suited for all patients, might do harm in the form of PIH. We need to develop a non-invasive test like ERA to evaluate endometrial receptivity during a fresh cycle. Right now, it is reasonable to perform freeze-all for all high responders and patients with abnormal progesterone levels. It is not clear if all normal and poor responders will benefit from this strategy for the reasons I told you earlier. So finally, we have reached from the follicle, gone through stimulation, selecting the correct dose, doing the right pre-treatment, doing a good egg retrieval, good laboratory embryo transfer, freeze-all for the correct indications, and then given the couple a beautiful baby. So once again, thank you so much, Dr. Chandravati, Dr. Sunita Chandra, Dr. Umesh Jindal, Dr. Amita Pandey, all the delegates for having been with us through this entire, I think, 1 hour of journey from the follicle to a live birth, and of course the UP chapter of IFS and MK or IVA division for once again organizing a brilliant meeting. So thank you everybody, and we can take some questions.
Thank you, sir. Dr. Amita ma'am, you'll have to unmute yourself. Please unmute yourself. You can now unmute yourself.
Thank you, thank you. So, Dr. Jatin, I am still reeling under the impact of this wonderful, fabulous, brilliant, awesome, mind-blowing presentation of yours.
Thank
and
you.
all I can say is, ye dil mange more. And I'm sure the rest of the audience would actually agree with you. So before we conclude, I would request Dr. Chandravati to just give a few of her comments, and then Dr. Renu Makkar to just briefly summarize before we can take up the questions. Dr. Chandravati ma'am, are you there? I think Dr. Chandravati is not here. So I would request Dr. Renu Makkar to just summarize very briefly the major important highlights of sir's presentation so that we can move on to the questions now.
Dr. Renu Makkar ma'am, you can unmute yourself.
Can you hear me, Amit?
Yes, yes, very clearly.
Okay. So this was an excellent talk as usual, nothing new from Dr. Jatin. We all have been a fan of his. And to conclude, I must say that this session was a crisp book on IVF stimulation. This was the perfect presentation. Thank you for highlighting the importance of the ANTAG and the agonist protocol, because we all have faith in agonist also, in spite of antagonist being there. A very good point given by Dr. Jatin was HPA-HMG, which we all have experienced. Maybe the number of eggs, they are less, but the quality of oocyte is always very good with HPA-HMG, and he's given all those reasons to highlight that. There is one question I wanted to ask him. What is his take on giving FSH at the time of trigger? Does he have any experience, Dr. Jatin? Can you hear me?
Which trigger, the HCG trigger or which trigger?
The HCG trigger, have you ever given the FSH? Around 300 of FSH at the time of trigger?
No, we don't. We have never done that. So in fact, we omit the HMG FSH dose on that day morning also.
Okay.
Yeah.
And other thing which I wanted to know, what is your experience in your patients about the FSH and LH receptor polymorphism? Because what we feel, if the AMH is around 1.5 to 2.5, the things are good. But the moment we go beyond 3 or 3.5, we don't get the good number of oocytes, and somehow we feel the FSH receptor and LH receptor, they have some problem there. What is your opinion about if we get the FSH and LH receptor polymorphism tested before we go for the first stimulation even?
Yeah, I think that's an excellent point you have made. In fact, it should be a routine test now. because compared to the cost of an IVF cycle, it's not very expensive. And I think we should do the FSH-LH receptor polymorphism test for all. Like AMH is a compulsory test, I think polymorphism should be also a mandatory test, because the patient is already spending so much on an IVF, and then in the first cycle you find out, oh, she is not responding, she's hyporesponder, follicles have become stagnant from day 7 onwards, and then you find out she has a polymorphism. So it's always best to have it checked before you start. Or if you are starting with HMG anyways, because see, the treatment for the polymorphisms is either you give a higher dose or then you start with LH right from the beginning. So if you are anyway giving HMG protocols, then maybe you could bypass the test. But it's an excellent point you made. So I think you should have it as a part. And it's easy to do. It's available easily.
Okay. And do you do it frequently in your patients, or you don't do it?
We do it if they come with a history of having done IVF in previously before coming to me, then I usually always do it. But if it's a first cycle and if I see a good AFC and young patient, then I try to avoid it.
How do you pre-treat them? I mean, the like supplements, adjuvants before starting the stimulation protocol? Because I know that you have been using ubiquinol and resveratrol. Any other thing?
We give something called mTOR, which has arginine and I think carnitine or something. There are 2 amino acids in that. Yeah. So we use a combination of mTOR and UBQHR for 2 months before they start.
Okay, that's a very good advice. Thank you. Thank you. Thank you.
Audience, where to get these polymorphism tests from?
Gen Explore. All the genetic companies, they do it.
Now,
regular labs may not be doing it, but you have to approach your genetic lab, whoever is there. I think they're all over India, so should not be a problem.
I think one company from Bangalore, they are doing it. The name of the company is Swagene. They are doing it at a very low cost.
Huh. It's less than 7,000. That's interesting because here they charge 7,000.
It's around 7,000-8,000.
Same. So the same thing we are being charged.
Amita?
So now can we move on to the question?
Yeah.
So I think Manjusha is waiting. Dr. Manjusha, I think a few of our UP chapter IFS members are eagerly waiting to actually put up their questions. So I would request Dr. Manjusha. I think she cannot unmute herself.
Ma'am, now you can unmute yourself.
Yeah. Thank you so much, Dr. Jatin, for taking us systematically through the thicks and the thins and the tips and the tricks of IVF. I mean, hats off, mind-boggling, what a presentation. Maza aa gaya.
Thank you so much.
One of the things which keep intriguing me when I look at the patients who have conceived through IVF and then later come to us in the routine obs gynae OPD is that many of them are on a cocktail of progestins. They are taking as many as 3 or 4 different progestins, oral, injectables, vaginal, plus HCG. So what is the rationale and what in your opinion should be the scientific basis of selecting which progestins and how much and till when?
Yeah, so that's an excellent point. In fact, I mentioned most of that there because I invariably see prescriptions with 15 drugs written, with absolutely no logic. Means everybody is getting aspirin, heparin, all kinds of things like you correctly said. So as I said, in a fresh transfer, either it should be only 50 milligrams in oil progesterone or just a 90 milligram gel once a day, or maybe 200 milligrams of a capsule, maybe BID or TID vaginally, or it's all or dihydrogesterone 30 milligrams daily in TID, 10 milligram TID. So it should only be this one preparation. There is no need to give vaginal with dihydrogesterone and also give an injection every 3 days. Some people, they give the injection also every 3 days. So all that is just too much of support. So basically you just need to select one. And in the frozen cycles, it's quite kind of double that, okay, 100 milligrams in oil or 40 milligram dihydrogesterone or maybe 800 milligrams micronized capsules or maybe 90 milligram BID gel. So it has to be, or it can't be 2 or 3 of them together. And aspirin, of course, most people give because you're giving high dose estradiol and maybe to improve implantation rates. I see a lot of unnecessary use of low molecular weight heparin also, which are, pretty painful and bruising injections. And I don't know why, but a lot of clinics give heparin to everybody after transfer, which is generally not indicated. So we have to be, as you correctly said, it has to be just that much. You don't need anything more than that.
And what about the use of DHEA sulfate and coenzyme Q and things like that as a co-prescription?
Coenzyme
Either
Q and resveratrol I have been using the preparation. In fact, yesterday we had a webinar. If you attended, I don't know, Neharika had organized on for male infertility, use of adjuvants. So there also we had a small discussion on the female part. So as someone, I think Sunita or someone pointed out that I use UBQHR, which is a combination of coenzyme, ubiquinol and resveratrol for about 2 months prior to stimulation. And DHEA we stopped using about 2 or 3 years ago because now there are 3 major RCTs which clearly show that it has no benefit in poor responders. In fact, we are waiting for the results of the T transport trial, which is
Yes.
60 days of testosterone.
Gel, testosterone
60
gel.
days of testosterone followed by long protocol and HPHMG for about 200 patients in each arm. And the results should be out, but whatever few leakages have come, clearly that is showing a good benefit. Because if you look at basic physiology, you need 60 days of testosterone and not the 20 days or 10 days that all of us just give the gel and say, okay, ठीक है 20 दिन लगा दो. It doesn't work like that. So right now, okay, everyone is giving 20 days of the testosterone gel. DHEA, as for our clinic, we have stopped using for last 2-3 years. Testosterone, once the results of this trial are made public and published, definitely I think 60 days of testosterone scientifically makes a lot of sense. Because we know poor responders have reduced androgen levels. So, and we thought DHEA would supplement that, but it doesn't. So direct testosterone is what we need.
Thank you, sir.
I have one question. Suppose the progesterone level on the day of EP is very low, then what do you do?
Yeah, so there are 2 options here. One is you refreeze the embryos, and that is why I said not do it on the day, but do it a day before, so you don't thaw the embryos. If the progesterone is less, then just don't thaw, because refreezing, although there are papers which say that it's fine, results are good, I'm not very comfortable doing that. So day before ET is okay to do it. If it is less than 10, you can switch to intramuscular progesterone, wait for 2-3 days, and then reschedule the transfer. If she's downregulated, it doesn't make a difference. But my problem with this paper, which I showed the slide, because it's being showed in all the international conferences, become a big thing. If progesterone is less than 10, don't do ET. My problem is that most of the European papers which come are on vaginal progesterone. And if you look at the original monographs of, Crenone gel and all that, when it came, it was very clearly said that it goes directly to the uterus and bypasses the systemic circulation. So those levels, although they may be adequate locally in the uterus, they don't reflect in serum concentration levels. So I mean, it's kind of a debate now that what is correct and what is not. But that paper shows that if it is less than 10, they have shown a reduction in pregnancy rate. But if you saw the slide, it was at 50% instead of 60% with more than 10. So it's not that you don't get pregnancies. That paper shows that it's 10% lower.
Actually, sir, there is a problem if you are using dydrogesterone or this vaginal macroprogesterone. You don't get serum levels. You are very right. So you really cannot compare the levels with intramuscular progesterone and with oral or vaginal.
Yes.
So I mean, it's a big loophole in this, and let's see what.
Yeah, and the monographs are very clear that it will not show in serum.
It is
effective.
Definitely. It will not give serum levels. So my question is like. Do you have any experience of using medroxyprogesterone instead of antagonist in donor cycles? I mean, the donors, are you using medroxyprogesterone in place of antagonist?
Because all this came in last November, December, first time, So we just started in 2 donors and the lockdown happened. And then we've not gone back to YouTube. So right now we are back to antagonist.
Yeah. Second is how to decrease miscarriage rate in FET cycles in PCO patients. I mean, I'm doing 100% FET cycles in PCOS, but early miscarriages are very common and it is very bad. I mean, it's disgusting for us and for patient also. So what to do?
No, so you have fine-tuning which you
can do. For, I mean, their embryos. I did first cycle, early miscarriage. Second cycle, again, early miscarriage. What to do for that?
So basically, see, we know that they have more mitochondrial defects than normal people, especially the insulin resistant ones. So maybe correction of that, good diet, exercise, myoinositol for 2 months prior to IVF.
Everything.
So finally, 10% is what you will get instead of 18-20%.
I think it's more than that, sir. I think it is in PCOS especially. It is more than that. It is not 10%. I am compiling my data, but it is more than that. Yeah, it is more. And it is very frustrating for patients and for doctors also.
No, but that's why the mega set HR is very important, because that's why I kept highlighting early miscarriages, because that's about PCOS only.
Yeah.
They are clearly showing significantly reduced. In fact, they're showing only 5% miscarriage with HPH.
Let's
so
see.
I think that's one of the biggest benefits. Even if they say it's a non-inferiority trial, As far as pregnancy rates are concerned, for me, what really caught my attention was the reduced miscarriage rates.
Reduce
So I
miscarriage
think
rate.
that point, that's why I kept stressing on it, and it has to be taken very seriously.
And one more thing is, what is your take home for luteal phase support in FET cycles?
If
Not
you
in fresh
wanna,
cycles, in FET cycles.
artificial cycles, you mean estrogen?
Yeah, artificial agonist and E2 progesterone.
Yeah. So until recently, we were using the gel twice a day, or micronized vaginal progesterone, but still 60% of my patients, they like to take the oil injection. So 100 milligrams
Okay.
in oil has been my favorite for 25
okay.
years, and people
Yes, yeah.
hate me
That
for
is what
that.
I wanted to hear
And
from you
everybody
actually.
hates me for that, but somehow I feel it works beautifully.
Okay.
And only if the patient complains that I can't take it, then I switch to all these other things.
Okay.
But I'm looking forward to the trials on 40 milligram dydrogesterone, because that will solve a lot of problems.
Yeah. Thank you. Yeah, Amita, you can ask for another doctor.
I was just wondering if anybody else in the audience wants to put up his or her question. Dr. Achal wanted to ask some questions. So, Dr. Achal, if you're online, can you just put in your question to Dr. Shah?
Dr. Kumudni bhi hai wahan par.
Dr. Kumudni ma'am, you can unmute yourself. I made you co-host. Please unmute yourself.
Good evening, sir. And sir, I want one question.
Unmute yourself.
Previous cycle, luteal phase. As you told that we can use antagonists on day 2, 3, 4, and then we can start with the stimulation. Can we use it in luteal phase too?
Luteal phase for
Previous.
the dual stimulation?
No, sir.
Previous luteal
You told
phase.
that
No.
we can use
I know.
antagonists on day.
There were 1 or 2 publications of using it in the luteal phase. Yeah, but this day 2, 3, 4 is very easy, very convenient, and extremely effective. So there's no reason to give it in the luteal phase. You might as well give it on day 2, 3, 4.
Okay, sir. And sir, as you told regarding pre-treatment, that OCPL may lead to miscarriages and all. So can we get ideal pre-treatment protocol from you for hyper-responders and for poor responders?
So high responders, see, if you have given them methoxyprogesterone acetate, if they are anovulatory, amenorrhoic, and you've given a progesterone withdrawal, they come in on day 2. Now they are not going to have a dominant follicle. So you can start from day 2 directly, your FSH or HMG, whatever you prefer. Otherwise, if you want to schedule the cycle, then use norethisterone. Like I told you, maximum 7, maximum 14 days. It works wonders, and it doesn't cause oversuppression like OCP.
Nothing.
So these 2 are the best according to me.
So in case of high LH, like in case of...
Your voice is breaking.
You will have to unmute.
In case of high LH, in case of PCO patient, where we get a higher level of LH, should we normalize it less than 10, then start, or can we start stimulation?
So what I would recommend is, instead of doing so many hormone estimations, you just give antagonist on day 2, 3, 4 to all patients. That is what I am following now. It works fantastically. So you are taking care of all the categories. The poor responders, you are getting your uniform cohort. In your PCOs, you are suppressing LH. In your high progesterone, you are reducing the progesterone. And even in normal responders, today time was short, but there is a slide where even in normal responders, Blockil has shown you get higher pregnancy rates and more oocytes if you give antagonist day 2, 3, 4. Yeah, I showed that actually. Yeah, you get 3 more oocytes with the antagonist. So as a, just general protocol, instead of like how you used to give OCPL to everybody, now you just give instructions that day 2, 3, 4, everybody takes 1 shot of cetrorelix, and it doesn't really add on to the cost too much compared to the IFS cycle, right?
Thank you, sir.
I've been doing that now, and the best thing I am noticing with day 2, 3, 4 antagonists is the synchrony of the cohort. I'm sure a lot of you have realized in antagonist protocol, one follicle in 30-40% of patients, one is bigger than the others. You get dominance, because sometimes you start on day 2 evening, day 3, and a lot of poor responders, follicular recruitment has already happened in the late luteal phase, because they have short cycles, those with 20-day cycles, 22-day cycles. So there your day 2 is also very late. So if you just give this antagonist pre-treatment, you take care of all these categories.
Beautiful.
Thank you, sir.
Amita, unmute kariye.
Ma'am, please unmute.
Dr. Achal wanted to put in some questions. So, Dr. Achal, are you there? Dr. Achal and Dr. Parul?
I don't see Dr. Parul ma'am over here. Achal ma'am, I don't see Achal ma'am also ma'am in the names. Maybe they have logged in with some other name.
I think if Dr. Sunita feels that it's all right, and if we do not have any
Yeah,
more
yeah, you can bind up and you
we
can.
wind up. Dr. Jatin Shah, before winding up, we need to get one promise from you that please, please, please.
From me also, we need you again.
Please
Yes.
honor us by at least one talk every year.
Yes,
You know,
yes, definitely.
Rejuvenating.
Definitely. My pleasure, no problem. You ask Sunita, I told her yes in 1 minute.
Yes, I will.
So,
Sir, it's always a pleasure to.
It's a pleasure to hear to Dr. Jatin Shah. And so, my gratitude, my special thank you to you, sir, for taking out so much of time from your precious time from your busy schedule to be with us today, to address our queries, and to give us such a lucid, wonderful, brilliant presentation of yours. Of course, my special thanks also to our patron, Dr. Chandravati, to Dr. Umesh Jindal, our guest of honor for today, our academic partners, the MCure IVA group, who have actually put in so much of effort to organize everything so wonderfully and so usefully. And of course, last but not the least, my wonderful audience, because no webinar, no program can be successful without a good, receptive, active, energetic audience. So thank you all. Thank you so much for being with us.
Thank you, Amita. Thank you, Sunita again.
Thank you, sir. Thank you so much. Thank you.
Thank you so much.
Rajiv sir, may I request you?
Thanks, Amit, Rajiv.
Thank you, sir.
Yes. Yeah. Thank you, Dr. Amit.
Hey.
On behalf of MCure IVA division, I would like to thank respected Dr. Sunita Chandra, Dr. Chandravati Madam, UP IFS chapter for organizing such a wonderful webinar. And it is always pleasure and treat to watch Dr. Jatin Shah to have in webinar. A lot of fan following sir is having. And we still are asking the webinar recording which we have done from IVA division. So thank you, Dr. Jatin Shah sir, for having a wonderful webinar. And I will also like to thank Dr. Umesh Jindal and wish her all the best for 30 Vision conference. Thank you, everyone. Thank you, audience, and thank you for team for organizing such a wonderful webinar. Thank you. Thank you very much.
Yeah. Thank you very much, sir.
Bye, everyone. Bye.
Bye.
Thank you, sir. Thank you.
This recording will be available in 48 hours. We'll share the link soon.
Thank you, Amit. Thank you so much.
Thank you, Sunita ma'am.
So beautifully. Thank you.
Thank
you. And अमिता को thank you नहीं बोलूंगी क्योंकि अमिता और मैं तो एक
अमिता मैम ने वैसे वंडरफुली मतलब पूरा ऑर्गेनाइज किया मैडम
She is always so good and she is always there. यही तो खासियत है अमिता की.
Special thank you very much to you, ma'am. You have organized all the thing very well, ma'am.
To Dr. Sunita for roping in Dr.
Yes, madam. Yes, madam.
Actually, बहुत
academic was possible because of her.
अमिता मैम, even that सुनीता मैम मेरे को भी डायरेक्टली मेरे को फोन करके कहती कि तुम कुछ नहीं करोगे, तुम्हारा काम मुझे करना पड़ रहा है.
So, ma'am, before we close down, I'll just play a video, which is our pre-launch video, where we are going to launch IVF Virtual Academy, and all 140 webinars will be available on it, including this one. So, just before we close.
Yeah, sure.
Hello, doctors.
New initiatives, IVA. That means, hello doctors. With season's greetings, I take immense pleasure and privilege to welcome you in our forthcoming new initiatives, IVA. That means IVF Virtual Academy. It is actually made for you and for your networking to make it more stronger as a knowledge partner. To make things sustainable, we will be requiring your continuous help. MCure has been always in the frontier to offer innovative solutions in healthcare through its quality medicines and quality and scientific services. Our aim is to remain trusted and preferred partner of yours so that we can serve millions better than before. IVA is one of the such fantastic initiatives which has been conceptualized, which has been designed, and after that it's going to be launched by our medical marketing team. And needless to mention that without your continuous and incredible support and encouragement, this would have not been made possible. Thank you once again for helping such kind of initiatives to come into reality. Thank you so much. Good day.
Good morning, dear doctors. At the onset, let me wish you and your family a very happy and prosperous Diwali. In view of current situation when everything was at a standstill, IVA and IVF division of MCure has emerged as a strong academic partner to proliferate the science. IVA collaborated with regional and national societies and international speakers to conduct more than 125 plus webinars, Materna School of ART and Pro Zindagi webinars. With 550 plus experts and 280 plus topics we have covered, we thank you all the doctors and societies for their incredible support. Thank you very much for your support. Thank you.
Good morning, friends. Recently, we have noticed how the world is volatile, uncertain, complex, and ambiguous. And there was a vigor for digital transformation. MCure, being a most innovative and trusted healthcare partner, took a positive step to bring all the experts in the field of infertility on one platform to discuss the recent trends and development during the difficult times of pandemic. This initiative is only successful because of keen interest of practicing infertility specialists in the country and even experts from overseas. I, on the behalf of IVA and IVF division of MCure, take an opportunity to thank all the faculty and delegates who kept us motivated and supported for this more than 125 webinar under the theme of Programming 28. Thank you very much.
Hello, doctors.
Ma'am, thank you for being there. So IVF Virtual Academy will be the thing which we will be launching soon, and it will have all the recordings what we have done during this period. So thank you for staying with us, Rajiv sir, and Sunita Chandra ma'am. With your permission, we can now close the session.
Thank you.
Thank you.
Sunita madam, thank you very
Thank
much.
you, madam.
Thank you very much.
Bye, Amita. Bye-bye. Bye.
Bye.